Today we have Jeffery Roskelley with us, who is a clinical social worker and psychotherapist. He works as a trainer and consultant for Sound LifeRecovery. In his role, he is responsible for providing training and clinical supervision to mental health clinicians who specialize in co-occurring disorders. He also offers individual psychotherapy, primarily employing cognitive behavioral therapy and acceptance and commitment therapy to address a variety of issues such as addictions, trauma, anxiety, depression, and psychosis. In addition to his clinical practice and supervisory duties, Roskelley plays an integral role in the SPIRIT team, a part of the University of Washington's Department of Psychiatry. The SPIRIT team, which stands for Supporting Psychosis Innovation through research, implementation, and training, is involved in
It's
providing.
a bit of a mouthful.
It is. I like SPIRIT. Yeah.
Yeah. Keep it that bad
and training is involved in providing training and support to the Assertive Community Treatment program in the state. His focus is on cognitive behavioral therapy for psychosis and integrated dual diagnosis treatment for co-occurring disorders. And also, you're working on a project. Do you want to share a little bit about the project that's going to be available this summer?
Yeah, I'm working on an asynchronous training. So if anybody has interest in a co-occurring disorder approach that's based on a functional contextual model with an emphasis on severe mental illness and psychosis specifically, then I should have something available for CEUs sometime probably in the summer. So hit me up if that's something that you're interested in.
Thank you. And once you have that available, if you'll email me, I'll send that out to our consult group.
Great, terrific.
Yeah. So I'm going to go ahead and turn it over to you, Jeff. If you need something from me, I'm here. Just let me know.
Okay, great, terrific. So just to get things started here, some quick housekeeping. I think that I have about 40 minutes. We'll see. I can always edit. I always have much more stuff than I have time to present, but I think I've got about 40 minutes of presentation. This is just some excerpts from the trainings that I normally do related to psychosis. We're going to do, hopefully, we'll get to the part where we're going to be doing a little, some exercises together so that we can better understand some of the aspects of psychosis. So if you've got a pencil and a pen, you've got some way of taking some notes for yourself, there'll be a section where that will be helpful. So if that's available for you, then my suggestion would be that you take a moment or two and grab that. The other thing as well is I know that Zoom fatigue is real, but just so that you know, for the presenters, when we can see your face, that's so helpful. So I'm going to be doing a lot of didactic material, and that's fine. But when we're together in a group and discussing, then it's a wonderful cue of safety to be able to see your faces. So if you've got cameras and we're discussing as a group, I would really appreciate if you would use those. But again, it's up to you. Okay, so let's get launched into the presentation here. I'm going to be delving into understanding psychosis. And in my trainings on these topics, I like to start out with some of the historical context for the treatment of mental illness. And the reason that I do that is because in the case is that most mental health clinicians carry some basic hidden assumptions about severe mental illness and psychosis specifically. So if we don't address that at the beginning, then it has a tendency to filter out any new ways of understanding psychosis as a phenomena and how we might approach it. Now, most mental health clinicians still enter the field with little or no understanding of psychotic spectrum disorders. And then as a result, we're really unprepared when we encounter it in our practice settings. And for clinicians here who are specializing and have an interest in autism and neurodivergence, this is particularly relevant because studies indicate that an individual with a ASD diagnosis is about 50% more likely to be vulnerable to a psychotic break or to struggle with psychotic experience, right? So we know that there's a big overlap here. Now, psychosis is a broad human phenomenon. It's common across all cultures. It has complex biopsychosocial and spiritual elements, but really more so than just about any other mental health condition besides addictions, which is something else that I specialize in. Psychotic experience is medicalized, and it's considered to be an untreatable disease that can't be understood or worked with outside of the scope of medicine, right? Now, to understand how we got here, I think it's helpful for us to go back to the late 1800s and the emergence of germ theory and this growing perspective around that time of human beings, of a human body functioning a little bit like how a machine does. Now, historically, we might see why that would be the case, right? There are better instruments, scientific advances and theories, primarily Darwin's theory of evolution, gave satisfactory explanations for a human being that didn't, say, rely on old wives' tales or fables or legends. So little bits of matter randomly bouncing around, given enough time, could be all the creative forces needed for the miracle of life. And with the emergence of all of the wonderful machines, like, say, the steam engine, science itself showed that the material world could be understood and mastered, and it didn't really necessarily require any further explanation. So if we see the human body as a type of machine put together through natural random selection, then it started making sense not only as an ontology, so the world and everything in it is simply comprised of matter and doesn't require a creator, but even more powerfully in the types of results that were possible through this perspective, right? So it did get results. The discovery and advance in germ theory started a remarkable revolution that brought enormous practical benefits. So we see the body as a machine. If we understand its parts and how those parts operate, then we can fix it. Now, when it comes to disease, if the underlying cause, or to use more medical language here, if the etiology of that machine's breakdown through disease could be traced back to something like an infection, well, the logic goes, wouldn't that include the functions of the human nervous system where our thoughts, feelings, and behaviors originate? Now, if we follow this logic, then psychotic and other psychiatric conditions can be seen originating primarily, if not exclusively, from biological or hereditary causes. Now, again, there was justification for this kind of thinking, given all the advancements in medicine due to the germ theory pathology. So the four humors don't cause a person to get sick, germs do. And this type of perspective is what we refer to the medical model. But what's really important to see here is that it's a disease model of mental illness. It suggests behind these symptoms of mental illness, defined as pathological thoughts, feelings, and behaviors, that there's an actual disease process, or that there's a pathology there, a physical pathology, something that's akin to diabetes, and it's degenerative unless it's treated. And how do we go about treating something like that? Well, we would treat it as though it was a literal physical illness. Now, if we see a human as a type of machine and we start to treat it like one, then there are going to be implications. And the shift in understanding here precipitated a lot of practices that today we consider to be grotesque, right? These would be practices like involuntary sterilizations, or the removal of teeth or other organs like the stomach, the colon, the testes, the ovaries. These were all done in hospitals for individuals to, quote unquote, treat the severely mentally ill. We also had practices like insulin-induced comas or lobotomies. And these were widely used practices. Now, when we look back on it, right, it's hard for us to comprehend how this could have occurred. But for many of these physicians, I'm guessing that these practices seem to be compassionate. Because after all, if an organ becomes cancerous, then you just remove the organ. And it's this line of thinking that led to these kinds of practices. And ultimately, it led to the medicalization of how it is that we address thoughts, feelings, and behaviors that are causing impairment and distress. And you find it reflected in the very language that we use when we talk about the quote unquote symptoms of mental illness, right? We use this kind of language, they're symptoms. Now, I know that these aren't very pleasant things, of course, for us to be dwelling on, but it is important, I think, for us to stay with the trouble here a little bit, because there's something for us to learn here so that we can start to do better by our fellow human beings. To do that, we've got to start recognizing that we often do carry these hidden assumptions so that we can start recognizing them, and then we're not perpetuating the violence that's been perpetuated in the name of mental health. Now, we don't necessarily remove organs anymore, right? But if we still think that we need to remove pathological thoughts, feelings, and behaviors, then we're coming from the same mentality. So in the early 1900s, there was a remarkable advance in pharmacology that included great things like antibiotics and other drugs, which treated conditions that up to that point had been fatal. And it was, truly a remarkable development in human history. So in the 1950s, when antipsychotic drugs first emerged, it looked like that we might have discovered something similar for mental illness. Now, there was justifiably some excitement here, right? Because we finally had a cure. Unfortunately, the limitations of these drugs became evident fairly quickly. Now, the first iteration of these drugs, they achieve their effects primarily through sedation, if we're being honest. That's hardly a cure. You wouldn't say that you've cured diabetes by saying that you made somebody sleepy, for example. So although these drugs have significantly improved over time, they still don't change established functions in the brain either, such as our thinking, feeling, and behavior. And moreover, they only really achieve their therapeutic benefit for around 25 to 40% of people that use them. And that depends on whether clozaril is used. Now, the drugs work by decreasing or diminishing neurotransmitter signaling, and those neurotransmitter signalings are working on already established functions in the brain. So that's not a cure. Now, in many cases, it can be a helpful tool. For a lot of people, it can increase an individual's overall functioning and quality of life, but we can't think about these things as being a quote unquote cure for mental illness. Now, for example, antipsychotics are a type of dopamine inhibitor. So unlike antibiotics, they're not treating an infectious disease. What they do is they inhibit the action of dopamine. And dopamine is doing a lot of really useful work in your nervous system, besides just whatever mischief it might be doing in the mesolimbic or the mesocortical dopamine circuits in the brain, right? Dopamine is doing a lot of different work for you in your nervous system. So you can see how this can be deeply misleading, right? It creates an implicit assumption that psychosis is a type of a thing, like a germ, and that it's going to kill that thing or eliminate that thing, antipsychotic, right? Now, again, that's definitely not what it's doing. What it's doing is that it's decreasing dopamine signaling, and that's a very different thing. Now, they also cause side effects like tardive dyskinesia, which is a movement disorder, akathisia. That's a type of internal restlessness, a type of internal torment that a person experiences. There are other side effects like gynecomastia, which is breast growth in men. And these side effects can be just as debilitating as the conditions that the drugs are meant to treat. Now, again, we can't really think about these drugs as being a cure, especially if we're measuring our success by decreasing impairment and distress, right? So if these drugs have these kind of side effects, then it's a cost-benefit analysis, but it's definitely not a cure. Now, in addition, the idea that a chemical imbalance in the brain is caused by mental illness, that's actually been falsified in research as early as the 1960s. So the idea assumed that the human body is functioning like a machine, that the brain's mechanisms work a little bit like pistons in an engine, but further advances in brain imagery and neuroscience have shown that unlike a machine, living systems adapt to their environment. So a train isn't going to alter its engine based on the weather and the condition of the train tracks, but your body does change in fundamental ways based on learning from its environment. So whatever the human body is, it's not a closed mechanical robot. And that's why the chemical imbalance theory, which is a little bit half-baked to begin with, that theory was developed before much research and understanding was actually done on the human nervous system. That's been largely abandoned as anything other than a way to market psychotropic medications. Now, notice in this discussion on the treatment of mental illness that we're never really clearly defining what a human being is in the first place, right? Only that certain types of thoughts, feelings, and behaviors are pathological. They're disease-like, and that they deviate from something that we would say would be normative. But what's normal for a human being, right? What's a human being in the first place? We're never explicitly told. So there's a metaphysical assumption that's based on a reductionist biophysical understanding. There's never an explicit one. If we think of a human being as a type of machine, then we're going to treat it like a machine, and then we're going to see the results. So we're going to try to cut out, or we're going to try to eliminate what we think is diseased or pathological. So if we come to define the way in which we think about, so if you come to define the way in which you think about something as being pathological, then I'm going to think that I have to remove that thing, right? And then if you are the person that's having that thought, then, and you resist, then that's part of the pathology that I'm going to try to remove by increasing your quote unquote insight, right? So I'm going to try to take that idea away from you. And I'm going to be thinking that I'm doing something compassionate and helpful as a result. But if you're on the other end of that, then how are you going to experience it, right? You're going to experience it as being helpful, or are you going to experience it as being an act of aggression? Now, over the past 20 years or so, thankfully, we've seen how detrimental this kind of approach is in the field of addictions, right? But we stop short when it comes to psychotic experience, and then we end up in a battle that's defined by resistance as we're trying to take something away from an individual that they're clearly still using, their thoughts, their feelings, and their emotions. So in my work, I've come to see psychotic experience and how to approach it in a contextual and adaptive perspective, or a pragmatic one. And pragmatism as an epistemological approach comes from William James, and his ideas on psychology and philosophy are really at the root of how I think about psychosis. So William James sought to make explicit the practical consequences of ideas and beliefs. And he famously said, what's true is what works. And it's this philosophical lens that informed his approach to psychology, which is functionalism, the idea that thoughts, emotions, and behaviors aren't the results of biological activities of the brain exclusively, but rather are intelligent adaptations to contextual cues. So our thoughts, emotions, and beliefs are an ongoing dialogue between the conscious, subjective me and the objective outer world in which I participate. So I want to take a pragmatic perspective by defining what a human being is in terms of the outcomes that we would like to achieve, which would be better mental health, or as Stephen Hayes says more precisely, psychological flexibility, which refers to the ability to be open to and present with one's experiences, to be able to adapt to changing situational demands, to be able to shift perspective, and to be able to balance one's values and actions effectively. So what this involves is being mindful, adaptable, and committed to actions that enrich our lives. So taking a pragmatic approach means that we start from there, that we state in clear terms of what a human being is, and then from there we can ask, how does a human being come to suffer? And then we can ask the question, and after that, how can we help that person? So today we're going to be looking at a human being as an open, aware, intelligent system that adapts to its environment. And when we explicitly state it like that, then we can posit the following, that all deliberate behaviors, emotions, and beliefs, which are all different types of behaviors, even the ones that we categorize as being psychotic, are intended to keep somebody safe or to help them avoid aversive experiences, and in general, to help them solve life problems. Because after all, that's what our feelings and thoughts and behaviors do for us. It's the type of work they do, whether they're psychotic or not. Now, frequently, then what we're looking at is the quote unquote symptoms of mental illness then are creative attempts to cope with overwhelming life circumstances. And there's a lot of different ways in which we could define what a human being is, right? So I'm not making a true statement here necessarily. What I'm doing is I'm taking a pragmatic approach. This is the way in which I understand it, because in my personal experience and in my work with my clients, I find this way of understanding what a human being is the most helpful in regards to how I might help them. And more importantly here, how I can stop from creating further harm. Okay, so from this perspective, I'd like for us to think about psychosis a little bit more specifically, starting out with a more workable definition of psychosis. So we've got a good understanding of what it is, and just as importantly, what it's not. So the broadest definition of psychosis comes from the etymology of the word itself, right? With psyche, that refers to mind. Osis refers to a state or a condition or an abnormal process. So essentially, psychosis refers to an abnormal condition of the mind and the conditions of distress, dysfunction, and impairment that result from those abnormal processes of the mind. So specifically, what are these processes? What are these abnormal processes? Well, psychosis refers to the ways in which the mind diverges from consensus reality. So for example, what a person perceives through their five senses, that could be confirmed by other individuals that are saying, hey, I'm having a similar perception, right? Or through empirical means, like maybe we could make recordings. Oh, then we're all hearing the same recording. But if that can't be confirmed, then we've got something that we could describe as a hallucination, one of the quote unquote symptoms of psychosis. Now, similarly, we have ways of understanding, of interpreting and talking about our experience, where this departs dramatically from cultural and social norms, where it's resistant to interpretation, and we've got something that we might point to as being a delusion. Behaviors are something that we see a person doing. Those can also fall outside of normal behaviors, right? And so that we can define them as being psychotic. So for example, vocalizing in speech patterns that seem to be incoherent, referred to as thought disorder, that would be another symptom of psychosis. And similarly, standing or sitting or laying without moving in a rigid posture, that's also a behavior that would significantly depart from most people are doing. This is catatonic psychosis. And all of these that I've mentioned so far would fit under the subcategory of the positive symptoms of psychosis. Now, on the flip side, people can also not be engaging in behaviors that normally a person would engage in, right? So not having interest in things that normally a person would have interest in, or not having motivation that normally a person would have. And especially where we see these lack of behaviors seen with the positive symptoms of psychosis, then we've got something that we could call psychosis that's become problematic or difficult for a person. Now, frequently, multiple symptoms of psychosis are going to appear together for a person, or there could be one or two more prominent expressions of psychosis. Now, psychosis itself is something that occurs for all human beings across all cultures, all ethnicities, all genders, all economic classes. And the experience of psychosis is something that has or can occur for anybody given the right circumstances. So the way I like to think about it is that it's a quirk in the human nervous system, and it has a tendency to show up given certain conditions. Now, what I've described here so far as being psychosis wouldn't necessarily be a problem that we would have to have any concern about, because they're common, right? They exist in a continuum with common experiences or difficulties that we can all relate to, and they have a tendency to become more pronounced with stress. But it's also important to understand that psychosis isn't always just unusual, but ultimately benign experience. Psychosis is frequently the source of significant impairment and distress, right? Voices can be unrelenting and bullying. They can be loud or distracting or bizarre. They can be cruel and tell the person to do things that aren't good for themselves or good for others. Delusions can be terrifying. They can be isolating. They can be harmful. And in general, psychotic experiences can make it extremely difficult to be understood, to communicate effectively, to understand others, and to read another's intentions, to be able to focus, to be able to process information, and to carry out normal life occupations. And it's also important for us to keep in mind that it's not a skin encapsulated phenomena, right? So while it's awfully hard for the person, it can be also very difficult for the people around that person. So what has a tendency to happen here is that as a person is retreating into their own private reality, right? It's like they're receding into the cave of their own private reality, then everyone around them is also moving away, right? And as everybody else is moving away, the tendency to happen is for the person to become more and more isolated in their private reality because there's no feedback loop that's being established, right? There's nothing that's drawing the person back into a more shared consensus reality. Now, again, it's important to see that we're describing somebody's experience, that when we're describing somebody's experience as being psychotic, we're simply saying something that we notice about their behavior, right? Or what they're reporting about their experience and how that behavior and experience departs from what we would consider to be socially or culturally consensus reality. Rather than describing observed and reported behavior in most common in the mental health field, right, we use a diagnosis to provide a heuristic. So it's a way of understanding in shorthand quality the mental life of the individual. But the diagnosis is going to tell us nothing about the person that we're working with and how their inner experience might be functioning for them, what their values and their aspirations are or were, or what a fulfilling life would look like for them, and the ways in which their experiences has then posed a barrier to that life. So I want to go through some examples here so that I can bring this to life for you. We've got so-called delusions. Those can range from clearly malignant and harmful, as in the case of Jim Jones, whose paranoid and grandiose delusions led directly to the death of over 900 people in the Jonestown massacre, including himself, to pretty darn amazing in the case of Albert Einstein, right? Who imagined what time and space would look like from a perspective of a photon of light. A line of thinking that was not just a clear departure from consensus scientific reality, but was ridiculed by the scientific community as being clearly delusional. Now, notice that both of these would fit our more broad description of psychosis, but one of these strange sets of ideas departing from the norm resulted in a human catastrophe, the other in a revolution in science. Now, because we think of psychosis from the perspective often as a medical disorder, then it's easy for us here to miss that there's a flip side of this aspect of psychosis. If we think about a condition like diabetes, then we're talking about a biological pathology, right? We can't really say that there's a positive flip side to a disease. But that isn't true with psychosis, where a person's strengths or their superpower, so to speak, are often the flip side of the disability. They come together. So I refer to this with my clients as being the John Nash dilemma. And for those of you who don't know, John Nash was an American mathematician who won the Nobel Memorial Prize in Economic Sciences in 1994 for his work on game theory. And in 1951, Nash was diagnosed with paranoid schizophrenia. And then he spent several years in and out of psychiatric hospitals. The film Beautiful Mind, which I'm sure many of you have seen, is based on his life story. And he was once asked, given that you have such a brilliant analytical mind, how come you were unable to tell the difference between reality and your delusions? Which I think is probably was a pretty rude question to ask somebody, but regardless, somebody asked him that question, and he said, I never questioned the delusions because it came from the same place that the math did. And this makes perfect sense if we recognize what thinking does. It's intended ultimately to help us understand our lives and to solve life problems. So it's not necessarily the thinking that's flawed. If you've ever worked with somebody that has, say, paranoid delusions or grandiose delusions, you see that a lot of the ways in which they're thinking about it is actually the logic is watertight. Especially if the person is really bright, right? The logic behind it is solid, right? The math is good. John Nash's delusions were as elaborate as his mathematical theories, right? It's the ability to be able to place the thinking in context that's really at the heart of the issue. It's a question of perspective. Now, similarly, a person might hear a voice, but the actual experience as well as the personal and societal interpretation of voice hearing, that can massively differ from person to person and culture to culture. So again, we've got to take the context and the consequences into consideration if we want to understand what's actually happening for a person besides just slapping a label on them. So let's take Helen Schachtman next as an example. And Helen Schachtman was a PhD psychologist and an East Coast atheist. She came from a Jewish cultural background. And later on in life, she started hearing a voice, remarkably claiming to be Jesus Christ, who wanted her to start writing down what he was saying. Now, if I were to just end the story here, based on your experience with people saying similar things, how do you imagine that this story would end, right? How would you play out the string here with this story? Spend a moment or two thinking about where you think that this story might end if you don't know who Helen Schachtman is. Because this is how it really ended. After resisting, thinking that she was losing her mind, she did really think that she had gone insane. She finally relented, and over the span of the next few years, she dictated in perfect iambic pentameter, which is the language of Shakespeare, what was to become the Course of Miracles. And the Course of Miracles is a sophisticated non-dual exploration of Christian mysticism, something that Helen presumably herself knew nothing about, but the voice sure did. And the Dictations later became a book that's been the source of inspiration and spiritual guidance to hundreds of thousands of people. Now, when the voice was done, she never heard it again. Now, I want you to ask yourself a question then. Did Helen Schachtman have a psychotic breakdown when she started hearing that voice? Or was that voice the expression of her inner genius trying to express itself? And that's the John Nash dilemma. Now, what's similar and different with her experience with voice hearing and, say, a person who started hearing voices in her late adolescence, which started out very nice, and until she told them that she didn't want to interact with them anymore, at which point they became abusive, nasty, bullying, screaming all the time, and kept telling herself that she had to kill herself or that she would die if she left the house, right? Both similar experiences with voice hearing. I mean, both similar in terms of both of those people are hearing a voice. Now, if we start thinking about this from a functional contextual perspective, then we can start thinking about what function possibly could that voice be serving for that person? What work can it be doing, right? We want to shift our perspective to a functional one in that all thoughts, feelings, and behaviors are doing work for a person in one way or another. Okay, so let's think a little bit more closely here about two types of common psychotic experience, and we're gonna do this as a type of thought exercise. Maybe I should check the chat box though to see if there's anything that I should comment on. Okay. Okay, so I want to spend a little bit more time thinking about two types of psychotic experience. Those would be hallucinations in the form of voice hearing, and then we'll tackle delusions. And I want you to try this on as a type of thought experiment, right? So it's going to be a little bit like you're putting on a different pair of glasses to see something in a different way. Now, we're going to start out here for you using your beautiful and wonderful minds, your power of imagination to bring to mind the last argument or debate that you had, right? So bring that to mind and replay it as vividly as you can. Just like you're stepping into a scene, you're having an argument with, I'm sure that most of us have had the experience of being in an argument, and some of us maybe even more recently. So bring that to mind. And notice how you can replay it in your head, right? Like stepping into a movie scene. You're seeing the person's face, you're hearing what the person has said, and notice that you can keep the argument going, right? You can make your own arguments and imagine what they might say in their own voice, and then how you might respond to that. Now, imagine that you can step back then and look at your own thinking mind a little bit from a distance. So it's like now you've stepped out of the movie scene, and now that you're out of the movie scene, you're sitting as an audience member, just aware that it's a movie, right? Now, from this perspective, I'd like to ask yourself these questions. How do I make the distinction between my imaginary debate partner in my head and the one that I debated with in my so-called real life? If I was just communicating with this imaginary debate partner, wasn't I functionally, quote unquote, listening to what they were saying and responding to it? And then ask yourself a question, am I hearing a voice in my head? Now, don't worry about definitively answering the question, right? I just want you to try these things on and see what happens in your experience. Now, the next thing that I'd like for you to ask yourself is, to what degree do you have conscious control over your own thinking? So, for example, how many times did you involuntarily do exactly this? Argue with somebody in your head, even though you didn't want to, and it interfered with something that you wanted to focus on. And then ask yourself the question, if this is happening in your head, then why aren't you winning the argument? Why aren't you winning the argument and moving on? Why does that person in your head keep on arguing with you? Okay, now it's time for things maybe to get even a little bit more weird. Can you remember when you first learned how to think? Did somebody teach you how to do it? Do you remember working that out for yourself? Did you practice your thinking? So don't worry, there's not a single person on the planet that has any memory of us doing this. How we learn it and how we actually do it is a little bit of a mystery. All that we really know for sure is that in the here and now that we think. Now, if we consider that we didn't invent language ourselves or work it out for ourselves, then when and how did I learn to attribute all of this communication that's happening in my head as a me that's doing it, as opposed to just being aware of it? Is it possible that thoughts, like any other sensation, are simply something that we simply experience rather than originating it? And is whether or not we think a thought is ours or not ours actually a type of evaluation? Is it an attribution that's created by thought? Or in other words, is it a thought about the thought? Now, turn your attention towards your feet. We're going to do a little bit of a grounding exercise here. So what I'd like for you to do is to use your ability to intentionally focus your attention and direct it towards where your feet are making contact with the floor. So they're your feet, they're making contact with the floor. And I want you to ask yourself, am I feeling the floor here, which is not me? Or am I experiencing my feet, which are me? How is your thinking mind different from other sensations that give you information about reality? And is it really? Now, from this perspective, I want you to imagine that somehow that you find yourself in a parallel reality where people there are experiencing thinking a little bit in the same way, or where people are experiencing thinking in the same way as you. It's a voice that prattles on in the background. But instead of attributing it to an internal I, what they do is they attribute it to something that's happening outside of the self, right? So they're attributing it as something coming from the outside world rather than something that's originating from themselves. Now, this would be a little bit like attributing the sensation to your feet on the floor, right? It's the floor that's creating it. So this would mean that they hear their thinking as coming from the outside, as outside communication or outside information. Now, imagine that you start to explain how you experience it, right? How you're doing it. And imagine what their reaction would be. Now, is it possible that from their perspective that they would describe your experience as being psychotic, if we use the broad definition of psychosis, as being an experience that departs from consensus reality, right? Then you would be the weird one, right? The person that would be having psychotic experience. Now, before you start to say, oh my gosh, this is preposterous, this is exactly the argument that Julian Jaynes made for how most human beings experience thinking as little as 3,000 years ago in his groundbreaking work, The Origin of Consciousness and the Breakdown of the Bicameral Mind. Now, that was very influential in the recovery movement with voice hearers for this reason. There he makes the case based on evidence from a lot of diverse historical sources that the human mind once operated in a state in which cognitive functions were divided between one part of the brain speaking, second part of the brain, which was listening, and that's how people did their thinking. Until further integration of these cognitive processes integrated that experience into a unitary me or an I that's doing the thinking. So essentially, we learned over time to attribute our thinking to a me rather than an outside voice. Now, it appears due to neuroplasticity then that this attribute, this ability to be able to create a functioning me that's doing things, that's been passed on once the circuits are established. So now we do it. Most of us, this is how we do our thinking. Now, your sense of a unitary integrated whole of me then is actually a learned cognitive function that evolved fairly recently. So when we think about this from a CBT perspective, right, we're just using a lens here to think about auditory hallucinations or voice hearing, then we can think about it as a type of thought, or even an intrusive thought that the individual is externalizing. They're experiencing it as it coming from the outside. And this has been studied at length. So when brain scans are done of individuals that hear voices, we see that the Broca's area, which is a motor area in the inferior frontal part of the brain that produces speech, becomes more activated. Now, what this suggests is that auditory hallucinations are then generated in our speech and language areas when we speak out loud, but also when we're talking to ourselves in our heads as well, right? We're producing inner speech. And this connection between the activation of this brain region and voice hearing is really what informs this inner speech model of voices, that voices are perhaps a function of our inner speech. But how this inner speech is experienced as being outside of ourselves, well, researchers have proposed that when we're engaging in inner speech, then the Broca's area sends a signal to the region of our temporal cortex called the Wernicke's area that's involved in understanding speech. And this signal essentially says, hey, don't freak out. This speech is coming from you, right? So it's a neural circuit that's been formed that creates a certain function, an integrative function. Now, in individuals who experience voices, there's a reduction in the connectivity of this circuit that connects Broca's and Wernicke's area. And that results in an inability, right, to internally, to distinguish then between what's internally generated and what's externally perceived speech. So that signal that tells us, oh, hey, the speech is coming from me is altered, leading individuals to hear voices to attribute the voice to something that's outside of themselves. Now, did this happen because something went wrong with the brain, or did the brain simply adapt to create a new function? Who knows? But if a person wasn't hearing a voice before and they suddenly are, then that does mean that something's changed in the brain. And we call those changes in the brain neuroplasticity. Now, one might say, why doesn't this sound like me? And there's several hypotheses that have been developed to better understand that. So inner speech can occur, as we explored before, in other people's voices, right? The other thing is that we know that both inner speech, our own negative thoughts, and the experience of voice hearing correlates to stress, right? So where there are more negative thoughts and where there's higher stress, then a person is more vulnerable to the experience of voice hearing. Now, many people start to hear voices when they're struggling in life, and things like sleep deprivation, drugs or alcohol, major life changes like bereavement, the end of a relationship. It can make it a lot easier for us to do this and not recognize our own inner speech. Now, another consideration is that inner speech is also intrusive, right? So when thoughts just pop into our head, they don't necessarily feel like that we're effortlessly generating them. They're just kind of the churn in the background, thoughts pop up. Now, when this happens, we can experience those as being as coming from somewhere or somebody else, right? So we've all got intrusive thoughts because thoughts work in relational networks. And so it's constantly churning in the background, right? maybe you can think of a time where you had a thought, like, for example, of walking up to, say, the edge of a cliff or something like that, and you get that involuntary thought in your head, right? Of the image of you jumping over the cliff. It's just something that happens, right? Now, we can apply these experiences then to voice hearing, and then we can understand how that what appears as intrusive thoughts or external projections of intrusive thoughts are actually reflecting our automatic inner thought process. And we can also apply this to trauma as well. So one of the hallmark symptoms of PTSD is considered an intrusive memory of a traumatic event. So we can see possible connections there when we consider voices that resemble abusers or reflect content that's associated with traumatic memories. The voice being kind of an echo artifact in the person's experience of that event. Now, this is an area of ongoing debate and research. These processes are extraordinarily complex and dynamic. So for our purposes, I'm focusing on one of the leading hypotheses regarding what causes voice hearing. But quite frankly, this is still a work in process. There's a lot to be learned here. And there are a lot of things about voice hearing that remain genuinely mysterious, like the case of Helen Schockman that we discussed earlier, right? There's things that we don't fully understand and maybe we'll never fully understand. So the complexity and the severity of audio hallucinations, like a lot of people talking in the third person, making running commentary, these can't be explained entirely by prediction error or the inner speech model, right? So the world is going to remain persistently weird around the edges, despite all of our best abilities to stamp it all out. Okay, so I'm going to stop sharing here because I'm seeing that I'm starting to run over my time. And I did want to leave a little bit of time for some discussion and to see if you've got any thoughts or questions about what I've presented today. And I'd love to hear from you about some of your experiences of working with psychosis, if you've encountered it, and what kind of thoughts or questions you have.
This is so thought-provoking, and I just really appreciate the neurodiversity affirming lens that you're bringing to psychosis. I think with the medical model that we're taught from, a lot of us really do miss this. I found myself really wondering, what is the course of treatment for somebody with co-occurring ADHD and psychotic symptoms? When you were talking
Say
about
that again. What's the question?
the course of treatment for somebody with ADHD and co-occurring psychotic symptoms.
Yeah, we see that there's a lot of overlap, right? And so, when we think about taking a practice approach to this, right? Especially if we're using evidence-based practices, then we do really have to be clear about what it is that we're trying to address. And then we've got to try to find some way to stage it, right? We've got to find some way of conceptualizing all of this and then applying things that we think might work for that particular thing, right? It's kind of the problem with diagnosis in the first place, right? It's not specific enough to really target what it is that we want to be targeting if we just have all of these sort of broad descriptions. So I would really have to know, how is the attention issues affecting that person? How do I prioritize that in terms of where the impairment and distress is coming from? And then what can I pull out from my toolkit that's going to be helpful in that regard? But I know that when I'm working with, like, let's say that I've specialized in psychosis, there's going to be this massive overlap with all of these different neurodivergent conditions. And there are some approaches that would be helpful in common, right? So we could work, for example, with helping the person identify and really connect with their values. That's something that you can do with any human being. But there would be more specific things, like, say, if a person was really struggling with, I even hesitate to use delusions, but that's how it's referred to. But and we kind of all know what we're talking about when we say delusion. If If I'm working with that though, right, then really what I'm trying to do is I'm trying to increase a person's ability to be able to take a different perspective. Because that's, as I pointed to, really at the heart of the issue. It's the context, right? So if I can start helping the person to start taking different perspectives, then I can help them with that particular thing. If I'm working with somebody more that has attention issues, then I have to understand how those attention issues are operating for that particular person. And then I can try to help them in that regard, because there'll probably be some things that would be helpful specifically for that person based on their specific presentation and what they want to be doing with their life. Does that make sense? That was kind of a roundabout way of answering that question, but it's always so specific. That's why I always try to think about, I always try to push aside the labels, right? So that I can get to the person. And then I know off to the side that I've got stuff that I can draw from that might be helpful for that person. But really where my attention has to be is with the person, right? Trying to understand a person in terms of how their life has shaped them, how they've gotten to where they're at that way in terms of their life circumstances, and then what that best version of themselves would be moving forward.
If there's time, I recently had a client inform me, an adult, that his mother had gone through delusions, and he didn't. I think he took her very seriously, and was offended by them. And he was like, she kept on talking about Iran-Contra in the 80s, and then it was, so, you know, and the thought patterns had changed through the decades, and remained. Do you have helpful ways for family members to understand, interact with, or even kind of look back on a childhood, right, where they were living for a time with somebody who was having, right, thoughts that could be recontextualized?
Yeah. I kind of wish that we would have had enough time to get to the talking more specifically about delusions, which are just stories essentially that we use to make meaning, or that a person uses to make meaning. Anybody can understand, right, that if you explain it to them, that we're using our thinking as a type of tool, right? Like we use our thinking to help us understand our world, our place in the world, what we're doing here, what we want out of it, how we fit in with other people, what we're all about. We use stories to do that. And everybody can kind of get that perspective. Oh yeah, I use a story that I use to explain myself and what I'm doing here and what I'm all about and what my intentions are and who I am. Right? So if we were doing this together as a group in a more if we had more time to do it, then what I would get you to do is to think about your role and why it is that you're here. And then I'd try to take that away from you so that you could experience the discomfort of what it is that that's like. Okay. So we all use ideas, and this is how we function as human beings. We use our stories and our ideas and our beliefs to help us make sense of our context. So it's no different if I'm using a super weird idea than if I'm using an idea that we can all agree that's groovy, right? All of you are assuming that actually I'm a social worker. And so that there's a reason for me to be here, right? And we can all agree that that's because I got a certain amount of education and I put, work into the field, and that I have a certain perspective that's worth sharing, right? This is just a story that we're all sharing that makes sense to us, right? Now, if it turns out that I actually never got that education, that I'm just some weird guy that started emailing, and saying, oh, I've got this great presentation that I want to present, right? And then if you found that out, then you would probably have a very different idea about the kind of beliefs that I'm holding about myself, right? But it would still be doing the same kind of work that we were doing together as a group consensusly, right? With the idea that I probably do have an education. So we can all understand that our thinking is a type of tool in this regard, and that's how we do it, right? This is how we function as human beings. Now, where the ideas become weird, where they're resistant to reinterpretation, like if you're engaged in a conversation with somebody and they become more and more like retreating away into their own private reality and their own private story about it, then that leaves them vulnerable for impairment and distress. And because we exist in a social environment, we're human beings, we're doing this together, right? So if you're retreating into a private reality that has no connection with the people around you, then you're losing context, right? You're losing the context of being a human being in some pretty significant ways. So that's what we've got to try to get across to the parents, right? That it's not, if a person has a weird idea, that it doesn't mean that they've got a disease. It just means that they've got a weird idea, and that there's probably some pretty good reasons why they're clinging so tightly to that particular idea. Now, that might be influenced by some biological factors. There might be some component that leaves a person more vulnerable to that. But you certainly can't describe the whole phenomena of doing what it is that we're all doing as a type of disease. And that's what the parents need to hear. The other thing that I didn't say that's really super important for us to understand as a group is that where there's impairment and distress, so where there's a psychotic break, the tendency is towards recovery. The tendency is towards people to get better. The tendency is towards people to stabilize. And we've done this really awful thing where we've said that somebody's got an incurable disease, right? Now, does it look like that for some people? Yes, it does, right? We've got to frankly acknowledge that some people are going to significantly struggle with impairment and distress, and that it's going to be extremely difficult. But in general, when somebody has a psychotic break, the tendency, the trajectory is normally towards recovery. So we don't want our parents, and we don't want the people that we're working with that might be struggling with this issue to get this idea that they've got this incurable disease that's like that would be worse than cancer. That was Eleanor Longden, who's a big person in the field right now, who works with voices. She developed this approach called compassionate approach voices. She was told when she was first diagnosed that it would have been better for her to be diagnosed with cancer, because then she would have at least a small shot of getting better. And, that's what we do. And that's what the parents think, right? Because societally, that's the way in which we think about it. So that's an idea, that's a pernicious idea that we're sharing as a society in our culture that's not helping us, that's causing us more impairment and distress. So is that a delusion? Kind of. I think we've got to try to cut through it in some way or another. So anyways, that's the way in which I work with parents, is that I try to get them to see it from this perspective. So it's two things. It's seeing thoughts, feelings, and beliefs as being types of tools that we're all using, even if a person's using them super weirdly. And then the other thing is that the trajectory tends towards recovery. So human beings are awfully resilient. We don't like to fall apart. We like to come back together when we do.
Thank you so much for your time. This was wonderful. Please do let us know when you have your training so I can send that out to everyone.
Great. Thanks everybody for your time and attention. This was really, really nice.
Mm-hmm.